Hello everybody, this is Wendy and Casey Woster. We work in the Health Partners ER group, and we are going to take the next few minutes to discuss tranexamic acid, or TXA. The objectives today is to explain how it works, its current uses, costs, contraindications, review of the literature, and its use in the community for trauma. So how it works. It's an antifibrinolytic. It competitively inhibits the activation of plasminogen to plasmin, so fibrin cannot be degraded, which allows you to make blood clots. Next, uses. Currently, it's used in elective surgeries and in OB for postpartum hemorrhage. It's also second line in the bleeding hemophiliac. The cost is about $100 per treatment. Contraindications include patients with thromboembolism risk or aneurysmal subarachnoid hemorrhage. The reasoning for the latter is because it has been shown in some studies to increase cerebral edema and infarction.
So what literature exists for the use of TXA in trauma? The largest and most discussed study on the use of TXA in trauma is CRASH-2. It was published in The Lancet in 2010. CRASH-2 is a large, multi-center, randomized, double-blinded, placebo-controlled trial. In all, there were over 20,000 patients who were enrolled at nearly 300 hospitals in 40 countries. The protocol involved giving 1 gram of TXA over 10 minutes, followed by an infusion of 1 gram over 8 hours. The primary outcome measured was in-hospital mortality at 1 month. Notable secondary outcomes were the occurrence of vaso-occlusive events and the number of transfusions required. Adult trauma patients presenting within 8 hours of injury and demonstrating significant hemorrhage or considered to be at risk for significant hemorrhage were included. Patients were also included if the treating provider was substantially unsure about whether or not to treat with TXA. Exclusion criteria were clear indications or contraindications for TXA. Results were as follows. All-cause mortality was 14.5% in the TXA group, significantly lower than the 16% mortality seen in the control group. TXA thus provided a significant relative risk reduction of 9% with respect to mortality. The estimated number needed to treat to save one life is 67. Further analysis showed a significant relative risk reduction of 15% in mortality due to bleeding. Subgroup analyses showed benefits to be greatest if patients were treated within 3 hours and presented with hypotension. There was no increase in PE or DVT in the TXA group. There was also no difference in blood transfusions. CRASH-2 has not been without its criticisms, which include concern over the treating physician determining patient eligibility when uncertain, the lack of a scoring system such as the ISS to determine how ill the patients were, the absence of a subgroup analysis for TBI outcomes, which was a major cause of death in the study. Also, having no reported increase in vaso-occlusive complications raises concern over inadequate reporting. Finally, the equivalent number of transfusions between groups may question the proposed mechanism through which TXA actually reduces mortality. Switching gears, another study called the MATTER study was published in the Archives of Surgery in 2012. This was a retrospective observational study of a trauma registry at a single surgical hospital in Afghanistan. Roughly 900 consecutive patients with combat injury were included, 293 of which received TXA. All patients received at least 1 unit of blood. Primary outcomes were mortality at 24 hours, 48 hours, and 30 days. This study also looked at thromboembolic complications. The TXA group had a statistically significant lower mortality of 17.4% versus 23.9% in the group that didn't receive TXA. The number needed to treat would be 7 based on these data. The odds ratio of survival was over 7 for those who received a massive transfusion. There were, however, a significantly increased amount of PEs and DVTs in the TXA group. Upcoming studies on TXA and trauma include CRASH-3 and the PATCH study. CRASH-3 will investigate TXA in the setting of traumatic brain injury. The PATCH study will try to select out sicker trauma patients and more closely investigate the occurrence of thrombotic complications. And as this is being done in Australia, it may be more valid to a trauma center in a developed country such as the United States.
Finally, its use in the community. We think that it would be reasonable to use TXA in the community, being most useful in hospitals with long transport times and limited availability of blood products. As always, this should not take precedence of airway stabilization, starting blood products, and transfer to a trauma center. Thank you.